Hi, my name is Dr.Ciro Martinhago. I'm a physician, a medical geneticist, and the director of Chromosome Medicina Genômica. Today, I'm proud and excited to announce a new partnership with Genomic Prediction Clinical Laboratory to introduce pre-implantation genetic testing for polygenic disorders to Brazil for the first time. We have here Dr. Nathan Treff, our colleague and partner, to present these details of this new technology in human reproduction. Dr. Treff has already published more than 100 medical articles on PubMed, and of course, also published several papers on this topic. Nathan, thank you for joining me today, and you have time for your presentation.
Great, thank you for the introduction and thanks for having me. We're excited to partner together and I'm excited to present our data around this new technology, LifeView, which expands what we can do with pre-implantation genetic testing. PGT has become a very common procedure for embryo selection in the United States. In 2018, 40% of IVF cycles included PGT. So it's becoming a more commonly used methodology. Until now, the primary application of PGT has been to test for chromosomes in PGT-A for aneuploidy. Essentially, this is just counting the number of chromosomes that are present in the embryo. We know that this technique actually reduces miscarriage rates and increases success rates in the first IVF transfer attempt. It's also been shown to improve outcomes with single embryo transfers. We also use PGT now for monogenic disease, and we'll talk about this in the context of what we're doing now with LifeView to be able to test for polygenic diseases. And then the third major category involves testing for structural rearrangements or translocations with PGT-SR. So this isn't a new concept. To be able to test embryos for polygenic diseases was actually proposed by Joseph Shulman and Bob Edwards in 1996. So the concept that we could possibly test embryos for a number of physicians to look at polygenic disease has been around for a while. And when we think about the difference between monogenic and polygenic disease, for example, in breast cancer, monogenic origins of breast cancer might account for about 5 to 10% of breast cancer. An example that many people are familiar with is the BRCA1 gene, where mutations are known to increase risk of breast cancer. What's left over, it has a number of origins, one of which is polygenic. So the majority actually of breast cancer that is explained by genetics can be done so in terms of polygenic origin. When we consider how we actually look at these two different types of genetic diseases, monogenic and polygenic, for example, with BRCA1, we're looking at one position, one gene in the genome, which is indicated by the purple bar there on chromosome 17. Now with polygenic testing, we're actually looking at several hundred loci across the genome, and each of those loci might have a different extent of impact on risk for breast cancer. We know that polygenic diseases actually account for many of the top 10 leading causes of death. The ones highlighted here, for example, include cancer, several cancers, diabetes, and heart disease. So these are significantly more common than monogenic diseases, which account for maybe 1 to 2% of the population, but polygenic diseases could account for anywhere from 30 to 50% of premature deaths. It also turns out that individuals or patients with infertility may actually have a higher risk of polygenic disease. So it's been proposed that infertility itself is a marker for increased risk of polygenic diseases like cancer, diabetes, and heart disease. So all of these things have led genomic prediction to develop a new test in the embryo that can predict the risk of polygenic diseases. One of the first papers that we published was to demonstrate you could predict human height from the genome within 1 inch. We also shown that you can predict a number of complex diseases, including diabetes, breast cancer, and prostate cancer, heart attack, and several others. We went on to demonstrate the ability to genotype embryos with high accuracy, and I'll talk more about that in a moment. And we've also demonstrated the clinical utility. So these papers are what I'll be talking about in the next few slides. Genomic Prediction Clinical Laboratory is the only accredited laboratory in the world that offers testing pre-implantation embryos for the risk of polygenic disease. And the way we've been able to do this is through analysis of the UK Biobank. There are 500,000 genomes with a number of phenotypes available so that you can develop these algorithms to predict the risk of disease. And we're using over 400 billion SNPs essentially to build these predictors. And then what we have done is to show we can sequence SNPs, a little over 800,000 SNPs in the pre-implantation embryo. And in our publication in the European Journal of Medical Genetics, we've shown greater than 99% accuracy in predicting aneuploidy monogenic structural rearrangements and polygenic disorders. There's several advantages. Most people think about PGT and the most common application or methodology is next-gen sequencing. The advantages of what we call SNP sequencing are many, but here I've listed a few, and one of those is that you have a much higher resolution in the genome, so you can detect smaller segments that might be imbalanced, in particular in PGT-SR cases. Because we have the genotyping information, you can distinguish balanced translocation carrier embryos from those that are actually genetically normal. We can also evaluate a number of quality control parameters that allow us to reduce false positives, which are quite common with other methodologies of low-pass sequencing. The genotypes also let you look at triploidy, all origins of triploidy, not just the XXYs, but the triple X's as well. And I think one of the coolest things about this technique is that from one biopsy, patients can add on polygenic predictions. So if they wanted to just do PGTA initially and weren't sure if they wanted to add polygenic, they could have the biopsies tested. Once they know how many euploid embryos they have, they might be more interested in obtaining the additional information on polygenic disease risk. And that's true for any indication, A, M, or SR. Polygenic predictions can be added at any time. So how do we know if it works? This really involves two steps. So the first is to confirm that we can actually get accurate genotypes from an embryo biopsy, and that those are equivalent to the accuracy we obtain in an adult. In our initial paper in the European Journal of Medical Genetics, we showed greater than 99.9% concordance in genotyping 800,000 SNPs in an embryo. And because we have this equivalent performance, essentially what we can do is then ask how would it work in adults where we know what their disease status is. And we have genotypes from adults, we have phenotypes from adults, so we can use that to evaluate how selection will work with embryo biopsies. So the second step is to do that. What we do is evaluate performance in adult siblings with known disease status. And the first part of that is to blind the DNA samples from several sibling pairs. You can then perform random selection where you're not using any genetic information. And you can also perform genomic or polygenic risk-based selection of one of the two siblings. After you've done each of these selections, random and genomic, we can unblind the disease status and compare the prevalence between those two, random and actual genetic-based selection. And these are the results of doing that for several of the diseases that we're able to predict risk of. And what you can see with random selection, a certain frequency was present here for breast cancer, 8%. And then we had a 15% reduction in the frequency when we used genetic selection of one of the siblings. And so what you see here are reductions in all of the diseases in parallel. What we also found is that in a series of 181 embryos that this genomic risk indicator or genomic index was actually higher in embryos which had an affected first-degree relative, and then lower in embryos that had no known family history. So there does appear to be a correlation between disease risk index score and family history. And what I showed earlier here, this is really looking at a relatively healthy population with no known family history. But we have had situations where patients have come in and had a family history and wanted to test for a specific disease. We've been able to model that here, for example, with type 1 diabetes, in a situation where there is a known family history, and you either have 2, 3, 4, or 5 siblings to choose from. These are the relative risk reductions observed when using genetic testing versus random selection. We also had a case involving a family where they already had a child with type 1 diabetes. So with respect to the embryos, these embryos had a first-degree affected relative. And in this case, we had 4 embryos tested. 2 came back as high risk for type 1 diabetes. I'm zooming in on one of those embryos, and what you can see is the percent risk and which ones are indicated as high risk, for example, type 1 diabetes. And we don't actually say that embryos have no risk of these other diseases. They actually have a normal risk for those additional diseases. We also had another case with a little more complicated family history, but here there was a second-degree relative with, for example, breast cancer that was of concern to this couple. It was a same-sex couple. And in their first cycle, we had 5 embryos, all of which were euploid, and 2 had a high risk of breast cancer. For example, the one shown here, you can see had a 24% risk of breast cancer. So we have a lot of future directions and goals, and one is to educate the public, and there have been some recent efforts in terms of developing public policy. And for example, Dominic Cummings recently wrote an article where he suggests that it would be worth having standard universal testing of all individuals with low-cost whole genome SNP sequencing to help improve healthcare. And in that article, he refers to the concept of genomic prediction. In addition, we had the European Commission recently issue a report on genome-wide association studies. And in that report, they talk specifically about what we're doing at genomic prediction with pre-implantation genetic testing for polygenic risk. There's several biobanks under development, which will help us expand our testing to more populations and more diseases, and one of those you can see up here is Brazil. And obviously we're really excited about our partnership and the fact that now in Brazil, patients can order LifeView testing through Chromosome DASA and Genomic Prediction Clinical Laboratory. And so with that, I'll thank everyone for listening, and I'm happy to take some questions, Dr. Ciro. Thank you.
Thank you, Nathan, for your awesome presentation. So, Nathan, seems like the genome predictions will be the future of genetics, right? I'm talking about prevention in medicine. It's essential, right? So in the future, probably we are going to looking for a new disease as well. Are you planning to extend the number of disease in the future, or you think?
Yeah, it's interesting. There's a few ways that we might be able to do that. Of course, new data that gets released to the public in these biobanks will be helpful as we have a larger sample size for different diseases like schizophrenia.
Yeah.
But we're also developing methodologies that, interestingly, might allow us to reduce risk of diseases that we don't have predictors for. So, for example, it turns out, there's a relationship between high cholesterol and heart attack.
Yeah.
And so, even if we didn't have a predictor for heart attack, the predictor for high cholesterol might actually help reduce risk of heart attack. So there's some indirect benefits of combining all of these predictors into one, what we call genomic index, whereby you might reduce diseases that you aren't directly testing for.
Yeah, I mean for genetics, like a medical genetics, right? So for your opinion, Nathan, is PGT-P a diagnosis test?
Well, the reports that we're issuing don't say things like this embryo is affected with type 1 diabetes, but instead we're saying that it has a high risk potentially, and as a result of our testing. So no, it's not the typical diagnostic test that people are used to with PGT-M. But for example, like with PGT-A, the methodology is really meant to reduce risk, and so we think about it as a risk reduction tool and an embryo selection tool. So when a patient might have more than one to choose from, instead of just choosing based on morphology, they can make a more well-informed decision based on risk of polygenic disease.
Yeah, so how you guys determine the risk of each embryo? Of course, you have some data from the fathers, right? Or from the father, from the mother, right? So when you put the risk, you put this embryo has the double of risk to have diabetes, or how can I explain this result for the patients?
Yeah, what we do is for each embryo provide a risk relative to the general population. And when there is a significantly elevated risk relative to the general population, we'll indicate that as a high risk in the report for that particular disease. And patients can choose to test all of the diseases that we have available, or if they're very interested in one in particular, they can limit it to that disease. So there's some options for patients to decide how they want to use the information available.
Sure. So what kind of patients do you think could do the PGT-P for all the population, general population, or just for the high risk families?
I mean, there's no reason for the general population not to use this test. I think our data shows that there is benefit, even when you don't have a known family history, to incorporate PGT-P into the embryo selection process. But I do think that you'll find, patients are very interested in this when they have some type of known family history. The cases I presented were, in fact, that situation where, for example, one family already had a child affected with type 1 diabetes, so that was very important to them to be able to evaluate that. So if you have, patients coming in for IVF and they might have this type of family history, I think we should be offering it to those individuals. Breast cancer, diabetes, heart disease, very common diseases, so I think it's unlikely to have patients that don't have a family history of something that is on our menu of tests available for polygenic disease risk.
Great, Dr. Nathan. It's a wonderful presentation. So thank you again.
Oh, great. Thank you.